Hi everyone. This is Dr. Chandrasekaran. I'm presently the Associate Dean in SRM Medical College, as well as I'm the Chief Operating Officer for the SRM Global Hospitals. I'll be talking to you about the complex toxicological presentations. So the outline would be, I'll be discussing with the real case scenarios, which I felt it is important to discuss. Of which the few are the Christanthus colonaceae, it's called as Oduvandhalai in Tamil, and the scorpion sting, snakebite and the shock, flowering agent poisoning, antidepressants, bronchodilator poisoning, and I'll summarize. So this is what I am going to speak. The first case what I'm going to discuss is about 8 years before it has presented. A 30 years old lady was presented with history of consumption of Oduvandhalai, that is Christanthus colonaceae, 3 handful of leaves, made it into decoction and mixed with jaggery and then give. This Oduvandhalai or Christanthus colonaceae is a very lethal poison. Especially it will be the symptoms and signs will start on the second or third day only, not on the first day. And it will end up with multi-organ failure, cardiac failure, ARDS, acute tubular necrosis, renal injury, hypokalemia, all these sort of things will come. And invariably, when a patient is taking this kind of poison with a jaggery, invariably they will die. It's very difficult to save them. So this case only we are going to see. On admission, she was perfectly all right, hemodynamically stable. However, knowing this poison, we do not want to take risk. We have given the gastric lavage. We initiated the patient on a multi-dose activated charcoal, and we started on N-acetylcysteine, which is usually used to save the patients with paracetamol overdose and yellow phosphorus poisoning. I feel this is more of an organ protector. It will protect the heart, kidney, lung. Most of the organs it will protect. So I feel it is an antioxidant which will help. So this one we have started 150 mg per kg as an IV bolus over 45 minutes in normal saline, followed by 70 mg per kg in 100 ml saline over half an hour every 4th hourly. This was given along with supportive cares. And day 1 to day 3 was uneventful except hypokalemia, which was corrected by potassium chloride infusion and magnesium sulfate, as all of us know. On day 4, the patient developed tachycardia, and it was ranging from 130 to 180 per minute. She also developed tachypnea, 34 per minute. Of course, the saturation was maintained well. The ABG was showing severe metabolic acidosis and hypokalemia. So here, the severe metabolic acidosis cannot be corrected with sodium bicarbonate because it is coexisting with hypokalemia. If you correct with sodium bicarbonate, the potassium will further become low. So these are the dangers we are facing. So having a severe metabolic acidosis, we cannot give sodium bicarbonate, and because hypokalemia may get precipitated. Here already the cellular level poison it is, mitochondrial level it will act. Already the shift, already the oxygen deprivation will be there. Now giving the sodium bicarbonate will always cause shift left. The dissociation of oxygen will not happen at the tissue level. And having the cardiac failure, renal failure, everything, the patient will go for worsening of pulmonary edema, and hypernatremia can happen. So these are the things we have to keep it in mind when you manage these kind of patients. So what is the right choice? The right choice is to go for dialysis. So having hypotension, tachycardia, so it's like CRRT is the best option, but unfortunately, the patient was not affordable, and city like Salem, we won't get it. So she was given sled 8 hours a day, it was started. And as the day goes, the potassium correction, magnesium correction, hemodialysis, the hypocalcium was corrected, the phosphate was corrected, all these micro elements were collected, and supportive care was continued, N-acetylcysteine was continued. With all these things, the patient gradually improved, metabolic acidosis gradually decreased, and everything got settled. There was no more requirement of dialysis. Hence, the patient was discharged on the day 13. So here the take-home points are N-acetylcysteine is very useful. Whenever there is an acidosis and hypokalemia is coexisting, better to go for dialysis. And of course, multi-dose activated charcoal will be very useful in plant poisons. So early and aggressive meticulous care has saved this patient. So another was a 19 years old girl with history of scorpion sting. We all know that the scorpion sting is very dangerous, life-threatening in children. But you must also know that it is not uncommon to have adults presenting with life-threatening complications. She was initially treated with local anesthesia and local doctors. As she developed breathlessness, severe cardiogenic shock, hypotension, within 12 hours of reanimation, she has been shifted to higher center. When we received the patient in the emergency room, the BP was 70 Curie, the heart rate was 180 per minute, the respiratory rate was 46 per minute, and the saturation was only 46 percentage, and the CBG was high, and the ABG was having severe metabolic acidosis. This was the presentation. So we didn't have the hope that we can save her. Anyway, having that in mind, that she's very young, we should try our best. We initiated the patient on noradrenaline and dobutamine, started with high flow oxygen, and planning for intubation. And while we are preparing intubation, we started on high flow oxygen. The insulin infusion also was started. So emergency intubation was done. And once you intubate, there was pink and frothy secretions coming out of the tube like a fountain. So we have to maintain that. So we are given ventilator support with an optimum PEEP. Already BP was low. So we have maintained between somewhere around 5 to 8 the PEEP, and we made inspiratory expiratory system as an inverse ventilation, 2:1, and FiO2 was 1. And in order to prevent further worsening and then mismatch, we are paralyzed and sedated. So the demand from the body will be less. So this is after settling, after giving paralysis, sedation, ventilator setup, and she got settled in the emergency room. And it took some time for us to shift. By the time we put paralysis, sedation, ventilator support, everything, the saturation was 94. You can wonder when the BP is low, how the monitor is showing the saturation. Of course, when there is severe metabolic acidosis, there will be peripheral vasodilatation, and that can always so the saturation. So this is not only here, you will get this kind of picture in sepsis, this kind of picture in any metabolic acidosis, and also you will see it in aluminum phosphate poisoning. These are the conditions. Despite having unrecordable BP, your pulse plethysmography of the pulse oximeter will be shown, and the saturation also will be identified. So luckily, at this juncture, in the emergency itself, we could achieve the saturation. But unfortunately, the BP was still under query, and tachycardia was there. So the echo was done. Echo was doing Takotsubo cardiomyopathy with EF was only 20%. As there was persistent tachycardia and hypotension, this combination will always invite us to give digoxin. So we give 0.5 mg slow IV stat. Despite of that, there was no improvement. Hence, we started thinking about Levosimendan. 6 to 12 mg per kg as a stat dose can be given. But having the hypotension already, giving the bolus dose will cause further collapse of the patient. Hence, the Levosimendan bolus dose was avoided, and only this dose, 0.05 mg per kg as a maintenance dose was started. After initiating Levosimendan, about 4 hours later, the BP has improved to 90/70. So after improvement of the little BP, we have raised the Levosimendan from 0.05 to 0.1 microgram. 1 microgram per kg. Sorry for the spelling mistake. 1 microgram per kg. Along with that, furosemide infusion also started as 2 mg per hour. And ivabradine was also started. As the blood sugar was persistently high, insulin infusion continued, and supportives like LMW, Spantacid, everything was given. So here we are given digoxin, Levosimendan, furosemide, and insulin infusion. So here, the two things what you see, the Levosimendan is a very good inotrope. It's an inodilator as well as cardiac. It will improve the cardiac failure, and insulin also will be a good inotropic agent. So this is after shifting the patient to ICU. Here also, the 180 heart rate was persistently there. You can see the number of inotropes and supportive agents we are given. And this was continuing. The BP improved to 170. After raising the BP to 170, now Processin was given. That is the drug of choice for scorpion sting. But we did not have the dare to start the Processin when the patient BP was very low. Now the process in 2 mg was started every fourth hour day. Surprisingly, after starting this process in when we are giving the third dose, that is about 12 hours, the BP also improved, the heart rate has come down to 110 per minute, periphery started getting warmth, and 36 hours almost we were successful in weaning out all the vasopressors. And the peripheries are warm, the BP improved. And ultimately, we could wean her out of ventilator on the third day. So here, which drug has saved the life? Of course, processing, but before processing to raise the BP, we have to depend on the Levosimendan, where the digoxin failed, other vasopressors failed, everything failed. We're not in a position to give fluid. Toxicological cardiomyopathy was there. The Levosimendan was the lifesaver. It raised the BP to some extent. Only then we could start the processing. So the dose of Levosimendan is 6 to 12 mg per kg as a bolus. Here we have avoided the bolus dose and we initiated 0.05 mg per kg per minute. We started this patient. So this will give good inotropy by troponin C sensitization, calcium sensitization. It will also give vasodilatation, so the pulmonary edema will come down. It is also cardiac protection because it acts as the level of myocardium, ATP synthetase. So this novel drug has helped us to save the patient. An young boy was treated elsewhere and brought to the emergency room with history of organophosphorus consumption. While we received the patient, there was no pinpoint, there was no secretions, the heart rate was normal. So we were having a query whether it is an organophosphorus or what. So we people are having the habit of labeling our organophosphorus poisoning whenever it is agricultural poisoning. So the saturation was only 78%. The lung was very clear, chest was clear, echo was having very good cardiac contractions. So having all these things in mind, we suspected probably it is not because of OPC poison or a bad chest or anything else. The ABG was showing, while taking ABG, we could see the chocolate brown color of blood. And the ABG, the PO2 was not low. And this was a saturation gap. When the ABG was not detecting the hypoxia, when the pulse oximeter shows it is saturation gap, though the patient was having central cyanosis, it was not improving to oxygen what we gave. We thought it is methemoglobinemia. And then we inquired further. We came to know it as a booster, which is flowering agent, nitro component, nitrobenzene component. So this have a typical, it's falling into the typical picture of methemoglobinemia, that is low SpO2, normal PaO2 in ABG, and a marked central cyanosis, and which was not responding to oxygen, dark brown arterial blood sample. So we diagnosed it as methemoglobinemia. Methylene blue was given. The dose of methylene blue 1 to 2 mg per kg, maximum 7 mg per kg. For his age, 5 ampoule was given. Despite of that, there was no improvement. So we cannot give beyond that. Already it was 2 days old. When we received it was third day. Patient also had hemolysis, hematuria, and refractory hypoxia. So we thought of going for plasma exchange. So if you don't have the machine for the plasma exchange, how do you do that in a peripheral setup? Give 500 ml of saline, remove 500 ml of blood, and give fresh blood of packed RBCs of 500 ml, and do it 2 or 3 times until the saturation improves. Most of the cases, we need only 1 or 2 cycles. So we could save the patient with the exchange transfusion. The lesson here is, in general, an unexplained hypoxia will be telling us about fat embolism or pulmonary embolism. Whereas in the setup of poisoning, one must always think about methemoglobinemia. And methylene blue is the right drug of choice. And however, if methylene blue fails, we need to go for exchange transfusion. That will help us. And though there are many cases we have seen, I thought it's the right time to mention about Radol. Tamil Nadu has banned this Radol poison, whereas in other states it is still available. The Radol is something mimicking the paracetamol overdose. Initially, they will be asymptomatic for the first 3 days. This will make the general practitioners not to give any medicine, give a false assurance to the patient relatives that you don't do it. And from third day onwards, there will be toxic hepatitis, liver necrosis, acute kidney injury, multi-organ failure, and death within a week or 10 days. So how do you prevent that? So treatment is N-acetylcysteine, 150 mg per kg in 5 ml of dextrose over 45 minutes, and then start multi-dose activated charcoal, 70 mg of N-acetylcysteine in same D5 over 30 minutes every fourth hourly up to 72 hours. At the end of the 3 day, if the liver function tests are normal, then you can be assured. If it is worsening, you may need to continue N-acetylcysteine. And if that fails, we need to go for plasmapheresis. And sometimes we don't even start, and we will start N-acetylcysteine. We don't even wait for the 3 days. We'll go for plasmapheresis whenever there is an affordability. Let us not take choice. Whenever the patient weight is less than 50 kg, whenever the patient is having chronic liver disease, a compromised liver disease, and the time window of more than 8 hours from the time of consumption to arriving the emergency room, or the consumption of retal was more than half of the tube, it is better not to take a chance. You go for plasmapheresis and 1 or 2 plasmapheresis. Sometimes if it is severe enough, even daily 1 plasmapheresis, maximum of 5 times we can give. And despite of that, if it is worsening, the only way to go is temporarily manages blood transfusion, current electrolytes, FFP platelets, all those things, and go for elective liver transplantation. A case of snakebite, hypotension, tachycardia, saturation was falling, and there is a rapid spread of extension of edema, hematuria. Whole blood clot was not falling. We given fluid, given ASV, given adrenaline, everything. Despite of that, the BP was low, not responding to the fluids. And what would have been? Echo was normal, IVC was normal, then suspected about endocrine shock. So especially in case of hyper, there is a chance if whenever you feel the hypotension is not getting reverted, especially in case of hyper, think about adrenal hemorrhage and thereby endocrine shock. So giving a steroid will always help us. Another 24 years old lady, Siddha doctor from Talaivasan nearby area was brought to the emergency with history of consumption of 40 tablets of hamlodipine. On arrival, the BP was very low. There was altered sensorium, tachycardia was there. Saturation was not traceable, and the respirator was 30 per minute. She was given IV bolus of fluid. She was started on noradrenaline, adrenaline, vasopressin, as well as insulin infusion as per the book. 1 unit per kg, 60 units per hour of infusion. Supportive care. Nothing was working. We also started on a glucagon. You know, the cost of the glucagon is 1 mg is more than 1,000 rupees. 3 mg per hour. The family has spent a lot of money on glucagon. Despite of that, the patient was worsening. The high-dose insulin was not responding. We gave lipid emulsion as a last-ditch effort. Antidiabetic bolus was given 2 to 3 times. The patient improved. After improvement, and this time itself, the intubation was done, emulsion was given, BP improved, 170 has come, and we continued. But despite of the treatment, 36 hours, we again lost the patient because of hypotension, all those things. No vasopressor. So what went wrong here? We gave the initial bolus. We should have given the infusion too. So the lipid sink theory is there. The internal lipid will block the receptors. And also free fatty acid theory. The free fatty acids of internal lipid will improve the cardiac contraction. So lipid emulsion was started, it should have also continued as infusion. So afterwards, for every case, we started giving lipid emulsion. When it is life-threatening, we give the bolus of 100 ml. Whereas when it is not life-threatening, at that stage, we will start the infusion of 25, that is 0.5 ml per kg per hour. This is to avoid lipid embolism. So unless it is life-threatening, don't give big boluses. And even if it's a lethal, when it is not life-threatening condition, start with 0.5 ml per kg. Go up to 2 to 3 days of infusion. The patient will improve. 70 kg man presented with an altered sensorium and unconscious state with convulsions. He was intubated, lorazepam was given, and ECG was taken. There was R wave prominent in AVR and QT prolongation. So that gave us a suspicion of TCA overdose. So what did we do? So it was tachycardia. Tachycardia was there, ventricular tachycardia, and the tendency is to go for amiodarone. As ACDS book says, adenosine. But here it is QT prolongation and sodium blockade. You should never use adenosine. What you should give, because it is TCA, give sodium bicarbonate. That is the drug of choice. That's the antiarrhythmia in case of TCA overdose. And of course, start give sodium bicarbonate and give lipid emulsion, which will be very useful. The treatment in TCA overdose is going to be sodium bicarbonate infusion. Start on inotropes, saline, and if necessary, ECMO can go. Whenever there's an VT, you give sodium bicarbonate. Sorry, it's not mentioned here. Sodium bicarbonate as an antiarrhythmic, magnesium sulfate, lignocaine can be given, and seizures always benzodiazepine. Of course, charcoal hemoperfusion, lipid emulsion are the two things that it can do wonders. Similarly, antipsychotic. Here also same thing. In antipsychotic, sodium bicarbonate is a drug of choice, defibrillation, magnesium sulfate. It was a case of torsades depointis. So torsades depointis should be treated as a VF. So defibrillation is the first thing, then magnesium sulfate, all those things can be initiated. Again, sodium bicarbonate is the drug of choice here too. A 20-year-old lady with 20 tablets of thiophylline, that's a combination of salbutamol and theophylline. She was very restless. The BP was 60. The heart rate was 147 per minute. And she had a tachypnea of 34 per minute. And the SpO2 was not recordable. It was very critical condition. The bad prognosis was explained. We're about to intubate, and the lethal dose was supposed to be 7.5 milligram per kg. What she has taken is 3 gram. For her weight, it is 50 milligram per kg she has taken. And NRBM was initiated, IV access was started, lorazepam was given, relcibincidin, MDSC was started, about to intubate, but we gave lipid emulsion. Okay, as there was severe metabolic acidosis, 40 milligram of KCl was initiated as an intravenous infusion. Hypokalemia was treated with the calcium gluconate, as the version shock, epinephrine, norepinephrine, all the infusion was started. And we thought of shifting the patient to ICU and do dialysis and hemoperfusion after stabilizing. But surprisingly, after giving lipid emulsion bolus, the patient improved. There was not even necessary for the dialysis or intubation. BP improved. We could not do dialysis. We did not want to do dialysis as the metabolic history started improving. We did not even ventilate. The patient was discharged on the very next day. So to summarize, always consider N-acetylcysteine whenever you suspect a poison is going to affect an organ, either a kidney, liver, or anything. Similarly, don't forget to think about extracorporeal removal and support. When the patient is hemodynamically unstable, not responding to any of your medications, especially because of poisoning, extracorporeal support will be very useful, because 2 to 3 days the poison's effect will go away and we can save. Similarly, extracorporeal removal in the name of charcoal hemoperfusion, resin hemoperfusion, plasmapheresis, therapeutic plasma exchange, transfusion, all these can be done. And insulin should be considered as one of the good inotrope, especially in calcium channel blocker and beta blockers. And Levosimendan, when every drug fails, that has a role in heart failure. And whenever it is an unexplained hypoxia, think about methemoglobinemia. And lipid emulsion has got a very significant role. And in recent era, one must not practice toxicology without having Levosimendan, methylene blue, lipid emulsion, and N-acetylcysteine. Thank you.